Hello, I'm Philip Bloom. I'm talking on adding ECP to Phaco emulsification, a topic very close to my heart. Thank you for asking me to speak on this interesting topic. These are my financial disclosures. Surgical treatments for glaucoma are principally outflow procedures. We're used to trabeculectomies, tubes. All of the new MIGS devices are largely trabecular bypass procedures. ECP allows the addition of a unique inflow effect to affect the balance between in and outflow. Transscleral treatments have been around for a while, but they're relatively blunt. They don't target the tissue precisely, and you don't know the end point of treatment, which is one of the many advantages of ECP. We're used to many more therapies for our glaucoma patients, including drops, laser, and surgery. ECP has long been a really good option to help us in this treatment paradigm. The laser endoscope in a 19-gauge probe has camera, light, and laser, and allows treatment and visualization of tissues that otherwise can't be seen. The endpoint of treatment is shrinkage and whitening of the ciliary processes. Under direct view, and it's easy to judge when the treatment has been effective because the process becomes slightly shorter, whiter, and that often reveals other processes behind it. We treat as much of the ciliary epithelium as we can, and there is ciliary epithelium between the processes, behind the processes, onto the pars plana. So over-treatment is absolutely not really possible with an initial treatment in a healthy eye. Rather like endoscopy, one shifts one's view to the monitor, having inserted the probe into the eye, having first inflated the sulcus. That's very important to apply viscoelastic behind the iris to bow the iris forward and the capsular bag IOL complex backwards, which is the very opposite of what's happening in a MIGS procedure, where, of course, we're taking the viscoelastic out of the posterior chamber and inflating the anterior chamber. So that's very important, both for visualization and remembering after the treatment that there could well be viscoelastic left there. During a normal phaco, we're used to removing the viscoelastic, but it isn't necessarily quite so voluminous and in exactly the same places. It's important to treat against the possibility of a pressure spike and for inflammation afterwards. I do this almost exclusively after the IOL insertion. Some people might argue that you get a better view before IOL insertion, but that's not my view. I think having the IOL in the capsular bag allows a very nice barrier, which allows you to open up the ciliary sulcus and the posterior chamber with viscoelastic. And also, if you do plan to put the IOL in after the ECP, then theoretically there could be damage to the zonule or the capsular bag that precludes the insertion. So this is what happens. We insert viscoelastic into the posterior chamber, bowing the iris forward. This is a previous slide showing the view that you get, and the red aiming beam there on the ciliary process. The foot pedal is applied, the laser is applied. It's important to allow the laser to be absorbed very gradually, and you adjust the power both on the machine with the laser power, but also with the proximity to the tissue. The closer you get, the more fluence there is, the more laser absorption, and conversely, if you're getting too quick a burn, you can withdraw it. This is now playing, showing the, it's a very hypopigmented ciliary process. It's not very pigmented, and it shows actually very nicely how the processes become white. And you can actually see behind that there are some other processes behind that you haven't seen initially, and the shrinkage of the process reveals them and allows you to treat those as well. So this is just a two-page primer that I've created for our trainees with all the tips and tricks for my about 30 years of experience of ECP, of showing, you know, what I think a nice little surgical tips on how to manage it. At the end of the procedure, very important to remove all the viscoelastic, and it's in places it isn't normally, so Of course, there is normally viscoelastic in the posterior chain, but not in the volume that we have following ECP. And also there's subincisional viscoelastic, which we wouldn't necessarily have to such an extent in a normal case. For all cataracts, important to have prophylactic antibiotics. We use intracameral cefuroxime in the UK, but we also use intracameral dexamethasone. There are preparations licensed for intrathecal and intracameral use, 3.3 milligrams per mil dexamethasone. I actually put that into the antechamber in all my complex cases, but in all Phaco ECPs. And personally, I give non-steroidal anti-inflammatories to all of my cataracts. Some people only choose to do so if there's a risk factor for cystoid macular edema, such as diabetes, but I tend to do it routinely, and certainly with ECP, anyone who's more likely to get inflammation or any complications. So I've been doing ECP for almost 30 years. Yes, I'm older than I look. And we've been collecting the electronic data on it for only a small amount of that time. So the data that I'm presenting really is since we've been doing that electronically. I regard, and I think others regard, ECP as the original MIGS procedure. It fulfills all the dictionary definitions of a MIGS procedure. It's conjunctival friendly. It doesn't need any extra incisions. And I think it has a place, as I'm about to talk to you now, with phacoemulsification. But I also think it has a very important place in advanced disease. So in someone who's had a failed trabeculectomy or a tube, I will then often, in a case like that, if they need further surgical intervention, ECP is right up there on my list of things that I think would be beneficial for the patient. So I'm going to talk you through a retrospective series of patients that we've looked at, and then show you some results from our work on a prospective study comparing Phaco ECP with ECP. That's a study performed, really Sheng Lim was the driving force behind that, and he's to be thank him for these slides. So we're looking at 100 eyes, mean starting pressures on maximum medication, just shy of 20. And you'll see the mean deviation of these eyes was quite high. These were quite advanced glaucomas, but all of these patients hadn't had no previous glaucoma surgery, and they all had primary open-angle glaucoma. These are the IOP results in 1, 2, 3, and 4, and 5 years, and you'll see the result is quite sustained. It is possible to repeat ECP, but it isn't always necessary because there is often a lasting effect. This is the survival curve. So at 5 years, we're looking at about a 60% survival, which is pretty good. And actually for a procedure that's very conjunctival friendly, and we perform it very simply in addition to phacoemulsification, I think that's a very important benefit. For many years, it also allows reduction of medication. In our study of 100, towards the end of the 5 years, we were on similar numbers of medications as they were to start with. But at years 1, 2, 3, and 4, they were on significantly fewer medications. So for many years, it does relieve the burden of medication use for these patients. So what's also quite interesting here, if you look at the visual fields, is that they started with a visual field mean deviation of about -13, and that's actually pretty stable. So this controlling the pressure, as we know, controls the rate of visual field loss. And the best thing we can do for our patients to help prevent visual field loss progression is to get the pressure down, which ECP does. These are the complications that we have seen. If you don't treat prophylactically, there is a propensity for more inflammation. So we recommend slightly more application of steroid drops topically. And as I mentioned, we give them intracamerally. And for the patients who failed and went on to other treatments, on at least 2 occasions, we performed further ECP. So moving on to the concept study. So this was supported by an unrestricted educational grant from BVI. And Sheng Lim is the main creator and driver of this study, and he's to be thanked for these results and for his passion in making this happen. And I was involved closely, though, in designing the protocol. And it was a multi-center study in the UK, in the treatment of primary angle glaucoma in patients with visually significant cataract, comparing primary Phaco versus Phaco ECP. Because the argument, of course, with all Phaco MIGS procedures is that the effect we're seeing is at least partly due to the phacoemulsification. Undoubtedly the case. That's why all certification now for MIGS should involve and does involve RCT evidence comparing the Phaco alone to demonstrate the additional effect of the MIGS procedure, and that's what the concept study was designed to do. These are the initial readings, and we did interestingly, and this isn't always the case with other studies, we did washouts at baseline, 12, and when we look at the 24 months data, we just looked at the 12-month data. So we washed these patients out, which of course means that we're seeing the true effect of the treatment. And we stratified the randomization of 160 participants, and we have about 80 in each group. So these are the baseline characteristics in an infographic. The top is the ECP, the second is the Phaco alone, similar ethnicities, mean starting pressures, and visual field defects. You'll see that these are much earlier glaucoma, so the mean deviations here are about -4 in both groups, -5, which is mild glaucoma, as opposed to the retrospective series I've just shown you from our patients at the Western, who tended to have more advanced disease. We're a tertiary referral centre, and I think that's why there's that big difference. This is a Gantt chart showing how the patients stack up in terms of randomized to the two groups and how many were lost to follow-up. And really very high retention rate, again, thanks to Sheng Lim's insistence that we do this properly. So here are the 12-month results. The Phaco group there on the top and the Phaco ECP group at the bottom. It says ECP, but of course it's Phaco ECP. And this was a masked study, so both the patients and those analysing the data were unaware of which treatment the patient had received. So the baseline IOP 24.5 in the Phaco alone, 25 in the Phaco ECP, and there was a statistically significantly greater drop in the Phaco ECP, and the difference being about 1.5 millimeters of mercury. So this is the first RCT evidence of the efficacy of ECP. That's long been one of the weaknesses of ECP, is that it wasn't supported strongly by RCT evidence, because it's been around so long in an era when RCT evidence was not quite so important for bringing a product to market. Now we have that evidence. So in summary, for the concept study, we had high retention rates in both arms. It was not a normally distributed intraocular pressure, so we looked at median IOP changes, and it was significantly superior in the Phaco ECP compared to the Phaco alone. There was a trend for greater success rate and lower medication use in the Phaco ECP arm, but that did not reach statistical significance. So just in summary, I think ECP is a very effective primary treatment, a MIGS procedure. And of course, it's a relatively low unit cost in health environments that are constrained by cost. You don't have the high unit cost of the device itself, and the more treatments you do, the more you make your investment pay. It has a number of interesting and relatively niche uses. It's used for treatment plateau iris. It has many benefits over the transscleral treatment, which we use in much more advanced, much more damaged eyes. And I'm not a big fan of the transscleral in, for example, the thermal treatment, because it can cause pops and disruption of tissues. The new micropulse treatments are interesting and quite effective and probably safer. But again, the evidence of that is not yet fully available. So that's as a primary treatment, but I think it has a very important place also as a secondary treatment. So there are units close to mine in London that once a tube hasn't worked so well as partially working, they will put a second or even a third tube. To me, that makes much more sense at that stage to consider slightly changing the treatment paradigm. We're very used with medications to combining the effects of inflow and outflow drugs, and doing that very effectively. And we wouldn't dream of using two outflow drugs of the same class, because we know that that's not going to have any extra benefit. So I would advocate intelligently combining inflow and outflow procedures. And that can also be as a primary procedure. So it's quite possible to do ECP in combination with an eye stent, for example, the so-called ICE procedure. And I find that the place of ECP in my practice is both early and very late in the treatment pathway. So just three little considerations I always sort of try to point out. Think about inflow and outflow. Because it's an inflow procedure, people forget about the outflow, but it's a balance between the two. For example, in someone with a very advanced glaucoma who has no outflow, you might want to be a little bit more cautious with the extent of the inflow treatment you apply, because you're going to affect that balance a little bit more unpredictably. For a long time with cyclophotocoagulation, safety has been a concern. For example, with cyclocryotherapy, safety is of very little concern above it's a surgical procedure. So, of course, there is the risk of complications, but the issue is efficacy, and that's why I'm very pleased that the concept study has demonstrated efficacy. So, but equally, if someone needs very low pressures, it's still my practice to perform incisional drainage surgery. We do a lot of trabeculectomies and tubes. It's important to apply the right treatment for the right patient at the right time. And visibility, not probability, that refers, of course, to the difference between endoscopic and transscleral treatments. It makes obvious sense if you're in the eye anyway and can apply the treatment to the target tissue very precisely. If you're with a transscleral treatment, it's often a different patient group. But as I say, the visibility, the ability to watch the treatment in real time, to apply it, to know exactly where it's going, and to adjust the endpoint of treatment is really, really very beneficial. I'd like to thank my colleagues at Imperial, but also very importantly the team led by Sheng Lim, who looked at the concept study. We've looked at the 1-year data. We're now in the process of collecting 2-year data, so we'll report back on that as soon as it's available. So thank you for your attention.